SG2 Perspectives is being renamed Edge Perspectives. Same great host, same great content. We're going to expand the way we cover data-driven market intelligence, quality, and operations. This is Edge Perspectives, a weekly conversation about the biggest insights that span market intelligence, quality, and operations with the Vizient Strategy Intelligence team and other experts.
Chronic care doesn't happen in a silo. We see this in action in our Vizient clinical database. 36% of CV discharges have a diabetes comorbidity. And on the flip side of that, 35% of diabetes discharges have a CV comorbidity. There's a strong interwebbing, a strong interplay of this is a patient that's being discharged for a CV event. Are we treating the diabetes that patient has? Are we looking at that? Are they getting the proper care?
Welcome to Edge Perspectives. I'm your host, Trevor DaRin. I have three colleagues with me today. We're going to tackle chronic disease and how health systems can and should connect it to more foundational, cost-related, efficiency-related initiatives they're already working on. We don't have to even explain what a big public health issue it is. We're going to tackle it from the health system perspective. So we have Josh Aaker, Jenifer Sarno, and Emily Fitt. A dearth of brains here to help me. But let's start with an easy question. Give me a definition. How do we define chronic disease? And you may not all be in 100% agreement on this.
So I lead our medicine service line subject matter expertise. So I have a lot of the chronic diseases in my service lines. When I think chronic disease or chronic care, I think longitudinal management and ongoing care, relationship building with patients that have a disease that are going to need more touch points than an average patient that doesn't have a chronic disease. High level, foundational, it's longitudinal.
Emily, you're right. I love the longitudinal aspect of it. When I think of chronic disease, I think of long-term, often progressives. I lead our cardiovascular team. I think a lot about congestive heart failure. And yet we also have dysrhythmia and AFib, coronary artery disease in my purview. But for me, it's that congestive heart failure. And when I talk about chronic disease, it is via geriatrics program, maybe a CHF program, a program focused on those patients that are touching a lot of different service lines. And often there isn't the coordination or collaboration that there could be because who owns this? Jenifer, how are you defining it?
Yeah, and I wouldn't say I define it differently. I just have a different perspective on it. I'm a nurse practitioner by background, practice in adult neurology, and now I'm a service delivery executive for operations and quality. I have a very patient-centered view of chronic disease, those patients that have a condition or a disease that require care beyond a year. So I'm managing symptoms, treatments, side effects of those treatments or medications. Ultimately, the goal is to prevent other comorbid disease and to get the best quality of life we can get for those patients when it comes to physical, social, mental well-being. Now, I work with operations and quality leaders in health systems that see these patients that are eating up capacity in their EDs and their hospitals. It's a cost burden. So how do we manage our chronic disease patients in a more efficient, cost-effective manner?
You guys didn't even disagree that much. You were pretty synced up. Josh, I heard you pitching chronic disease management can and should be connected to capacity and bed management initiatives. That might be one of the most effective ways to make progress because I've been really impressed with how much health systems have in the last 5 years been able to connect things like service distribution that have been so hard to make progress on, work on average length of stay, or taking that a step further and shifting where procedures are going to take place, including growth to ambulatory surgery centers and connecting it all back to capacity. Can we connect chronic disease management to capacity here to make an impact?
If you don't, you're going to run out of capacity. That's the base case. What we're really saying is, let's just use CV. Everyone knows about it. It often generates revenue for organizations. A lot of us are familiar with it. 2/3 of those inpatient discharges for the CV service line nationally are medical. So as much as we talk about growing TAVR, growing any of our inpatient procedural space, the only way we're going to be able to make a room for that is by moving some of our challenging medically managed fragile population to other sites of care. Hopefully, it's more upstream, so they're not having to take on any of that inpatient burden or challenges. If you're going to try to use your bed space for procedures that you are going to make a margin on, you will have to make room, often by moving those congestive heart failure patients, those kidney care patients, to other more appropriate staffed sites of care.
I really like your point here, Josh, because chronic care doesn't happen in a silo. We see this in action in our Vizient clinical database. 36% of CV discharges have a diabetes comorbidity. And on the flip side of that, 35% of diabetes discharges have a CV comorbidity. There's a strong interwebbing, a strong interplay of this is a patient that's being discharged for a CV event. Are we treating the diabetes that patient has? Are we looking at that? Are they getting the proper care? Or the flip side, maybe they're discharged with a flare-up from type 2 diabetes, and we are not treating the CV disease that's occurring. Thinking about how those silos are happening in chronic disease when it should be, how can we interlace our programs and our care to meet what the patient is actually experiencing? And a service line that does this better than others, our cancer service line, because these patients are so complex and have more needs than maybe a typical chronic disease patient. Cancer programs have put in a lot of smart care redesign efforts like team-based care, nurse navigators, dedicated ED triage protocols and spaces. We could take a lot of learnings from the cancer service line to our other chronic disease service lines. Chronic care doesn't happen in a silo.
Jenifer, as Emily was talking about this, I was thinking, do health leaders you're talking to connect chronic care with capacity? Are they the same conversation? Are they separate? What can we take away from that?
When I talk with health system leaders, this is one of the hot topics. Length of stay is beyond what's expected. So these patients are in the hospital, they're taking up beds. They're now developing complications. They're becoming debilitated. It's requiring more ancillary services. It's not just a capacity issue. Now it's a workforce issue. Now it's hitting complications. And then these chronic disease patients are being discharged to wherever they're being discharged to. And they're coming back to the hospital. So we see a lot of these chronic disease patients that don't have well-established care in the health system. We see that they're in the hospital for a long time. Then they have several readmissions in, say, a 60 or 90-day window, and yet we don't see any outpatient follow-up care. So when you start talking about team-based care, specialty teams, chronic diseases, going to that site of care selection, extremely important to think about how we can ease capacity by managing these patients, not just in clinics, not just virtually, but treating home as a site of care for chronic disease patients. So now we're being in our self-management disease programs, our community partners. We are bringing in remote patient monitoring. It's such a complex issue for a complex patient population that until we start to solve those kinds of issues, they're never going to be able to free up capacity for some of those other procedures that you were talking about earlier that are going to help improve margins.
If we just look at that readmissions perspective, I want to just throw out one stat. If we look at from 2023 to 2025, just in congestive heart failure, there's been a 15% growth in those readmission volumes. Think of all of that space, that mental time, those resources, that workforce hour that could have been used more appropriately. Again, readmissions are a sign that we didn't do as great of a job as we possibly could have in the entire healthcare system, not just in the inpatient system.
I want to hear more specifics. Jenifer, you started getting there, but I think this idea that we have to do a better job connecting the dots for patients, putting the pieces together. We've heard from patients that's what they want and expect. But if it was easy, if there was a financial incentive, health systems would do it. So I'm going to make it harder for you three. Trevor's health system has just hired you guys and paid you a lot of money. You're leading our chronic disease service line. And your first initiative might be to explain why this shouldn't be a service line. I don't know. But you guys have it. What are you going to do?
The first thing I'm going to do is not just roll out a program called chronic disease management without understanding the demand. That target population. That population is typically your patients that are chronic kidney disease, diabetes, hypertension, obesity. That's a great place to start. But is that the population that is increased demand, higher utilization, driving multiple ED visits, multiple hospitalizations, multiple readmissions in your health system? You have to start with what target population you want to use. If you create this without understanding the population well enough, you're setting yourself up for failure because you're creating a program without understanding the workforce that you're going to need and the resources you're going to need to support that.
The reason why we don't see as much program development around chronic care is that chronic care programs are not as profitable as, let's say, a surgical program. What I would do is try and figure out where the value is in chronic care. That could be from preventing inpatient admissions, exploring some value-based care, take on a little bit more risk. But also it could be growing what's lucrative right now, and that's specialty pharmacy. Thinking about those chronic, ongoing autoimmune and inflammatory conditions that need infusions or injectables. Thinking about our neurologic conditions that need infusions or injectables. There are even some specialty light medications for endocrine and metabolic disorders. You have to take a multi-pronged approach. Figure out where you can cut cost and figure out where you can grow revenue.
Is your real population the population that is most impacting the resource utilization you have? Is it a certain disease state? A certain demographic of population? Is there a certain geography that because of transport issues or food deserts, they're not able to develop their own healthcare, and so they have to use our healthcare system as the de facto front door to any clinic? When you start doing that, you can start finding these commonalities. Look, a lot of our PCPs have gotten good at that medication management, talking about symptoms. Bring them into the fold. Emily and I have been talking about cardiorenal metabolic programs. Often those can be physician-led, but physician-light. Use those parish nurses, use those community members, because it's easier, better, and cheaper, frankly, if that care is closer to the patient and at home than if they show up to your emergency department, have a readmission. That admission plus readmission, that's 13 days on average, according to our CDB, when you combine those. Do you want to use those 13 bed days for that one patient? Or do you want to have 6 TAVR patients that have flown through there in that same time period? That's up to you. From a costing perspective, I would want our procedures in the hospital and our medically fragile patients at home surrounded by care.
Those are all pretty good ideas. I like it. Let's go slightly smaller scale, not thinking about spanning a huge health system. I'm sure you've heard examples of pockets of success here. Part of me thinks that's some of the problem. It's like a disease-based program can be successful. You get grant funding, you get specific resources, you zero in on a specific population. But I'm sure there's some learnings and takeaways from those programs. Can you make them a little bigger than one disease? Do we have some good success stories? Josh?
One of the things that I think about is from an organization, and you may not exactly associate this with chronic disease, but they had a lot of challenges in their ED and their observation space. Do your analysis for your local market. They had a lot of chest pain of unknown origin. It wasn't clearly defined as a STEMI or an NSTEMI or something else. It was, we don't really know. And that's a real drag on the system, both on their ED and their observation. They deployed new technology. They had a new diagnostic test to help rule out heart attacks, all this great stuff. It got a lot of those patients out really quickly. Then about 30 or 40 days later, all those patients weren't being sent back out of the ED, and management went to the physicians of like, what's going on? And saying, well, we don't actually know if those patients are being re-seen. We kind of let them go, but we didn't see them being scheduled. We didn't see them showing back into clinic. It's easier and safer if I just hold on to these patients for a little bit longer until I feel comfortable to rule them out. So until the health system built an outpatient clinic and embedded in our EHR a direct appointment scheduling, there wasn't the psychological safety for all of those ED physicians to want to change. This is both a bigger issue, Trevor, but also at a really small issue of trying to make sure that you're empowering your frontline teams to understand the power of change, that we can move one population out and provide better care for them, which opens up the care that we are using for these other patients. Keeping these patients inpatient is not healthy for them. They are more exposed to hospital infections. Can we come together on this multifaceted way to make sure that we're correctly focusing on our chronic care patients? That may be super small and starting with just those diabetes patients that are always showing up, and you really need that social work, that support to make sure that they're having a real clinical pathway to success.
Maybe I'm just in a good mood this week. Here's my hyperbolic statement. Health systems have impressed me the last couple of years with their ability to bundle other initiatives around their internal bed management capacity initiatives and make pretty quick progress. Yes, it's going to be super hard, but if they can do that here, it would feel like a huge shift across the healthcare industry. What if we might actually be able to do it? Maybe I'm feeling optimistic today. I think we can. What could hold us back?
Very aspirational that we would want to do that, but this would result in a full-scale change of how we do healthcare. We would start the conversation up top very differently. We wouldn't call it chronic disease, we would call it chronic health. How are we creating programs that reinforce healthy behaviors independent of what are available for a patient out there? The biggest thing to realize is doing nothing, you are already behind. These are patients already in your EDs, in your observation. They already make your procedures that much more challenging because your patients are really fragile. Inaction is not something you can do. Instead, start talking with the frontline people that you have. How best can we move these patients through our system? What's challenges? Is it they don't have social support at home? Is it they're not able to monitor their glucose very well? Is it they keep getting lost in the system? We're not getting our echoes back. We're not getting our blood tests back. And we just need someone to be more on top of this. Different programs are going to look very differently. Emily and I get asked, what does a good cardiorenal metabolic program look like? And we say, we'll let you know when we see one. It's so new and so fresh. Because it's not a service line, no one really takes the financial ownership. It falls too much to everywhere. And that's why I think that enterprise leadership of helping improve chronic care is going to help everyone all through the system of care.
I'm going to flip the question. Instead of saying what will hold us back, I'm going to say what systems can do today. And that is bring it back to the patient and their care journey. What are some important milestones that happen in a patient with chronic disease? So one of the service lines I talk about quite often with systems is nephrology and kidney care. Luckily, when it comes to kidney care, we have different stages of disease. So a patient could be stage 1, which is the lowest acuity, all the way to stage 5, where they need dialysis. Can we map out important points along that journey and create workflows and infrastructure that meets those important points? For stages 1 and 2, we want to focus on early identification, prevention, potentially adding some specialty pharmacy like GLP-1s or SGLT2s into the mix. We want to slow that progression as much as possible. When a patient reaches stage 3 and 4, we want to start to stratify by risk. What is the risk of a patient crashing into the ED? How can we prevent that? And then we need to start having that conversation with patients and their families about how do you feel about kidney transplantation? If you necessitate dialysis, do you want to do it at home? Do you want to do it in center? Here are the pros and cons of both. What support does your caregiver need along the way? Start that conversation early so when that patient reaches the point where they are at stage 5 and they have end-stage renal disease, this isn't a surprise. This isn't a new conversation. We're able to appropriately avoid the ED in the inpatient setting, and we're able to slowly start dialysis and potentially reach transplant. Mapping that care journey and focusing on where can we proactively intervene to stop some of those negative outcomes.
I would love to reframe successful chronic disease management. We often hear people refer to healthcare in the US as sick care. And I would love to reframe it as chronic disease management is preventative care. As we treat these patients with chronic disease, we're preventing other comorbidities, we're improving quality of life. As I think about healthcare systems that I work with, they tend to think of putting chronic disease management on the shoulders of their primary care physicians and clinics and APPs, and bridging strategy and operations around chronic disease management is making it reimbursable team-based care, not just creating this unfunded heroics of primary care that has to deal with it. Healthcare systems could start to recognize success in that way.
What a great closing statement. Unfunded heroics. I love that because that's where we're at today. And I think huge opportunity for improvement. Thanks all three of you. Great perspectives, great stories, great insights. Thanks for sharing. Thanks for listening to this episode of Edge Perspectives, a podcast from Vizient. If you have questions or ideas for future episodes, please reach out to us using the email address in the show notes.